These patients have received a few no's before they get to us.
By the time they come to us, if they come to us 6 months earlier, the kidneys were working. Now their kidneys aren't working, or their liver isn't working.
At the University of Chicago, 2 transplant surgeons are redefining what's possible in modern medicine.
We aim to do all our transplants bloodless. If you don't need to transfuse somebody, they just do better after surgery.
We're doing bloodless heart transplants, lung transplants. The next realm to delve into is a bloodless heart-lung transplant. Yeah, we're always stretching the limits.
Your blood, your health, it's yours to decide.
I am so happy to be sitting with Professor Pablo Sanchez. He is the professor of thoracic surgery at the University of Chicago, very active as a lung transplant surgeon there. Also, Dr. Jeevanandam. He specializes in the surgical management of heart failure. He has done over 1,500 heart transplants. He specializes in high-risk surgical cases and bloodless cases. Thank you, doctors, for joining us today.
Thank you very much. Yeah, thanks for inviting us and having us on your broadcast.
Yeah, thank you.
Great. So let's dive in a little bit. This is really exciting for me. I'm really excited about this podcast. Dr. Jeevanandam, can you share a little bit about your background and what led you to this specialization, particularly with the bloodless surgery program?
My boss called me to his office. I said, Val, he's got good news and bad news. I said, well, give me the bad news first. He said, well, the entire transplant program just moved to Hahnemann. I said, well, what possibly is the good news? He goes, well, you're now the director of a program. And well, that's how it started. I wanted to hightail myself out of there as fast as I could, but they trusted me. I stuck around, and within a year, we were the largest heart transplant program in the country. That's kind of what got me interested in the different nuances of heart transplantation. In terms of bloodless surgery, it was interesting. My father had cardiac surgery, and I remember he had it in Arizona, and I went out there, and he had his cardiac surgery. I remember all night long worrying about him bleeding, kind of constantly stripping his chest tubes and wondering whether he had to go back to the operating room or not. Eventually stopped bleeding. He eventually developed Parkinson's disease. My mom is convinced that it was all the bleeding that he had after cardiac surgery where he got Parkinson's. So every single time we talk about that, my mom's always like, it's your cardiac surgeons, you guys bleed, and then you caused, that's why he got Parkinson's. So I'm constantly reminded of at least her perception of what bleeding leads to in cardiac surgery. I really then developed an interest in how to prevent bleeding. And at that time, there was a drug called aprotenin that just came on the market. That was a drug that was designed to decrease bleeding during cardiac surgery. So we started using that drug, and all of a sudden the bleeding dramatically got better. And then we started doing cases without blood products, which was kind of my shtick at that time. Because at that time, almost every single patient getting cardiac surgery got tons of blood. And then I did my first heart transplant in Jehovah's Witness, I think in 95. My interest in the kind of the bloodless started kind of as a personal experience with my dad. And as I've grown more experience as a cardiac surgeon, you realize that there are certain things that I do in the operating room that involve a lot of being meticulous and all that stuff that you don't see the change if you're comparing it to normal cardiac surgery. But if you have somebody who has a very small margin of error, that extra meticulousness, that compulsiveness actually makes a big difference. And that's why I started focusing on doing bloodless patients. And we probably do close to about 80 bloodless cases a year now.
Wow, that's significant. Great story. Dr. Sanchez, can you tell us a little bit why you got into bloodless?
I got into bloodless surgery because I came to the University of Chicago and Dr. Jeevanandam one day said, would you be willing to do lung transplants in high-risk recipients that require bloodless surgery? And I say, of course. And he had set up such a good program here that a lot of what you do around this, of course, it has to do with you, but it has a lot to do with the amount of support that you have around you. So developing a program as a transplant program or LVAD program or heart transplant program that is completely bloodless, it goes beyond what you do in the OR. It's getting anesthesia on board, nurses, and ECU, and all that for me was simple because Dr. Jeevanandam had already established all that here at University of Chicago. So the amount of Jehovah's Witnesses that need bloodless double lung transplant is small. We probably do 3 a year, but we aim to do all our transplants bloodless. So this is not just something that we looking at offering to Jehovah's Witnesses. We aim to offer to all our patients because we believe that these patients just do better. If you don't need to transfuse somebody, they just do better after surgery.
Pablo is being very humble, right? Because when we were recruiting him, I saw one of his papers where he had done 80 patients without uncycled patients without blood.
Yeah,
yeah. There was a huge number of patients that he reported on that he had done without blood, and I'm like, okay, if anybody's going to do these things bloodless for a Jehovah's Witness patient, it's going to be him. Doing Jehovah's Witnesses, as Pablo says, there's a lot of surgical component to it, but it's really, really building up the infrastructure and the trust, both for the patient and for the team in general. So we're kind of blessed by having a fourth floor that's the heart and vascular floor. That floor takes care of lung transplants, heart transplants, pre-op, post-op, ICU, and telemetry. In the beginning, when we started the program, people were trying to convince the patients to take blood, right? So you would bring them to the OR, you would get, they would come in, and the first thing the anesthesiologist would do is they thought it was their moral job to try to convince them to take blood and decrease their risk. And we kind of battled through that, and people started seeing our results, and we developed flags in Epic, and we developed a way to get consents before surgeries. We have a bloodless team that takes care of them before, and so no one else needs to get consent afterwards. And it changed the entire philosophy of that fourth floor, because no one's there trying to force blood on people. Makes our patients who travel long distances very secure that they can maintain their faith. And when you have somebody with a hemoglobin of 6, barely anybody on that floor flinches anymore because they know that they can get them through surgery. There's a certain amount of comfort level among our anesthesiologists, our critical care folks, our cardiologists, our pulmonologists. And, it's interesting. They've seen the results, so there's some amount of faith as well. That faith combined with our results have allowed us to be able to offer this in a comfortable way, right? There's no one's calling the ethics people. There's no morality and stuff like that. I mean, everybody understands their roles and they understand their comfort levels. I think that is what it's kind of, as Dr. Sanchez says, it's an entire, they say it takes a city, it takes a town, it takes a village. Well, this takes kind of an entire world. It's a very, very large process, but over the years, we've been blessed to be able to develop it. We're doing bloodless heart transplants, lung transplants. The next realm to delve into is a bloodless heart lung transplant. Yeah, we're always stretching the limits.
And just to kind of give me some perspective, what type of blood spend, like in an average other locations where we're having lung transplants and heart transplants, what would the blood order be?
Well, for hearts, the usual preoperative order sets probably 4 units of red cells, 6 units of FFP, and a pack of platelets. That's common. If you look at the ISHLT database, I think 53% of patients get some kind of blood products after their transplantation. And about 60% of patients get blood products after LVAD implantation. So it's pretty significant. I don't know, What do you guys do?
So yeah, we do exactly the same. But you were mentioning that manuscript that we published. We looked at the first 40 patients that we did bloodless, and in 40 patients we saved close to 500 units of red cell. So 40 lung transplants that did not get transfused. We compared to 40 lung transplant that went the normal pathway. So in those patients, we saved close to 500 units of red cells in the surgery. And after surgery, we saved another 200. Developing programs like this is not only give you the opportunity to offer to patients that otherwise will not be offered, in my opinion, leads to better outcome, but at the same time, it has an impact on how expensive you are, if you think about it that way.
It also makes everybody better clinicians. I'll give you the reason why. Is like after a heart transplant, a normal heart transplant patient gets bloods drawn every 12 hours. And they get blood gases and they do this and they do that. For our Jehovah's Witnesses, their first blood draws 2 days after their transplant. And then we do another blood draw 4 days afterwards, right? So it's 2, 4. And then after that, they need to have bloods drawn for their tacrolimus level. But that means that you are now managing them clinically as opposed to numerically. And it actually makes everybody, I think, better clinicians. And it actually allows them to take care of all the patients. At least when I do a heart transplant, it's rare that anybody gets blood, whether they're Jehovah's Witness or not. So that kind of ties in, not only does the bloodless medicine leads into better patient blood management.
Yes, definitely. I've seen that.
And I think the actual real physiological advantages of not giving blood, like especially in the lung transplant program, giving blood transfusions can cause trolley, and you get trolley in the transplanted lung, that becomes really problematic. I mean, you get a little bit of trolley in a heart transplant, it's probably okay, but in the lung, must be really pretty devastating. So if you can avoid that, it's just better care for a patient.
What are the steps that you take to optimize these complex patients to minimize your transfusion risk prior to even getting into surgery?
We look at obviously their anemia, right? So we want to have people with the highest hemoglobin possible. We actually wrote a paper on I think it was like 170 consecutive patients. And if their hemoglobin was greater than 12, their risk of mortality was dramatically lower than if it was less than 12. So we consider 12 as our optimization, but honestly, we get there about 50 to 60% of the time. A lot of times we just never get there. We operate on them anyway. But anemia optimization is one thing. Whenever we know we're going to do a procedure on people, we then give them a lot of vitamin K to bolster up their coagulation factors. Obviously, hold all their supplements, their herbal supplements, their Plavix, their aspirin, things like that. And then, when you talk about optimization from at least a heart perspective, optimization is considered trying to decongest the patient and get them to the operating room with a low blood volume. But with the Jehovah's Witnesses, you almost want them to come to the operating room with a little bit higher blood volume. So you have some blood that you could manage. And compared to our normal patients, we actually decrease their Lasix on the Jehovah's Witness patients, especially right before surgery, that, we're anticipating surgery. So we actually increase their blood volume, because one of the most important things that we do intraoperatively is what we call normal volemic hemodilution, which is we take their blood out before it hits the bypass machine, and then we reinfuse it back to them after the major blood loss has all been taken care of. That technique is great in terms of preserving coagulation factors and platelets. And the more blood volume you have, the better. So I think there is hematological optimization, which is getting their platelets and their hemoglobin optimized. And then there's physiological optimization, where we almost tell the cardiologist, don't optimize them too much. I like them a little plump because we have extra blood volume to work with. I don't know. How do you handle it?
No, exactly. So I think for us is also 12 the cutoff. heart disease and lung disease are a little bit different in terms of how these patients present clinically. So for us, what will be the need for intraoperative hemodynamic support? So either cardiopulmonary bypass or ECMO. And that's where I think how many people can offer bloodless surgery in lung transplantation, particularly. Because I think there are a few centers in the United States that say, yeah, we do Jehovah's Witnesses, but we do bloodless surgery, but they only do it for very, very, very low risk recipients. As you probably can see, we doing second and second people every year. So if you only offer these surgeries for very low risk recipient, you're actually not really offering to anybody these days. So being able to pick it up a notch and say, no, it doesn't matter if you have severe pulmonary hypertension. It doesn't matter if we need to use heart lung machine or ECMO or keep you on ECMO after the transplant, even if it's for a few days. You can do those things and at the same time kind of have processes around to reduce the need for blood transfusion. That's what you have to do. For us, the optimization is very basic and just related to what we need to do for these patients to get to surgery, but particularly the patients that we do bloodless, it's mostly the hemoglobin optimization, nothing else.
You kind of alluded to the fact that it takes a city to do this. So I like to think of a surgery as kind of like an orchestra, and everybody has their piece and everyone has their part. Who makes up your dream teams?
You have your surgeon, and then we have our fellow and our PA, or sometimes we have a second surgeon. So those are the people that there's about 3 people up in the chest, as they say. And then you have the OR nurse, and then you have an OR circulator. So there's 2 nurses that are taking care of everything. And then you have a perfusionist, and either a second perfusionist or a perfusion assistant. And then you have your anesthesiologist. So I would say that is kind of the minimum team that's in there: anesthesia, perfusion, OR, and then assistant for the surgeon. We've worked with 2 of our PAs for over 15 years. And I would say that, yes, I kind of run the cardiac surgical program, but they're the ones who actually probably perform the hardest part of it, which is, after we're done, the anastomoses, if they bleed, that's my problem, right? So at the end, the anastomoses aren't bleeding, but then you have oozing from the chest wall, you have oozing from the sternum, and those PAs have incredible amount of patience to stay in the operating room, make sure everything is stopped before we close. And they are the real heroes of this whole procedure. And sometimes they may stay 2 or 3 hours, and then after they close, they'll stay an extra hour in the operating room and make sure that there is no bleeding. Our take back rate so far, out of the last 400 Jehovah's Witnesses we've done, we've taken back 1 patient for a bleeding. And that's because we rather have them bleed in the operating room and open them up in the operating room than take them back. Right. And that is purely on the ORPs, who are just absolutely magnificent. And then you have our perfusionist. The last transplant I did, this was a big gentleman. We were able to save 2 liters, but that 2 liters normally is in their bypass circuit. So they have a lot of extra volume in their venous reservoir that they can basically, it's going to vacillate by 400 cc's depending on how you move the heart, how different things happen. You have a big margin of error. You take that blood away, they don't have a margin of error. So if you come to my operating room, you'll see alarms going off all the time, because there are alarms that you can't turn off when the blood volume goes below a certain level. And our perfusionists are laying right there, right? It's like having a hovercraft over a choppy ocean. And they're constantly going right up and below that line. It takes a lot of experience and practice to be a perfusionist that's comfortable enough to be able to do that. Then our anesthesiologist, when we try to save blood and everything, there's a lot of different positions we do for the patient. And so they have to be comfortable doing those positions. The biggest complication of cardiac surgery, whether it's transplant or anything else, doing it bloodlessly, is renal dysfunction. because you have less delivery of oxygen because your hemoglobin is lower on top. Our perfusionists maintain that by going up on their flows. Our anesthesiologists are experienced enough that they're not chasing numbers all the time. They're actually taking care of clinical patients. So that's why our results are so good, is because everybody's working together. That's the dream team, right? Everybody's got to work together to get this done.
Dr. Sanchez, if I'm your resident and you're training me in bloodless surgery, what are the key strategies, the things that you're never going to want me to forget and to take away as your student that makes bloodless surgery or patient blood management the best outcomes?
Ooh, I think you have to have patience, honestly, in my opinion. So to me, the bloodless surgery starts from the time you make a skin incision. But you cannot just go through tissue and not take care of those, little things on the skin or in the muscle because of course, when you get to the chest or around the heart and all that, definitely you don't want any of that bleeding. You have to be meticulous and precise and have, very precise dissections and so on. But it's a lot of wetness that can happen just from opening somebody's chest. So we take our time to make sure that by the time we enter the chest, everything else is dry. So we don't have a muscle that it keeps, oozing during the surgery. We minimize all that soft tissue entry bleeding as much as we can. That to me, it's is the number one step. I always tell the resident, you cannot get frustrated. So it's just got to take it slow, and it's believe that slow is smooth and smooth is fast. So so you just take it one step at a time. And I always tell my residents that my surgeries are boring because I always do exactly the same thing. So you just can scrub in patient one, or you will scrub in patient 1,000, and you say it's the surgery. It's like he hasn't changed, and I haven't changed it because through time I believe that that's kind of the sequence of steps that minimizing moves, and that you can repeat it and you will always kind of get to the same outcome. So I think that repetition of moves that you have learned through time that make you more efficient and you don't waste moves is the best way to teach.
I think what Dr. Sanchez says was so important, right? He says it takes longer. As I tell my residents and fellows, it's suture deficiency, which is the number one cause of bleeding. Most of my anastomoses, you go forward, you go backward, you go forward, you go backward. They do take longer. For a heart transplant, for instance, probably, the sew-in time is about 70 minutes, probably about 10, 15 minutes longer on a JW patient, just because we can't afford any bleeding at all. Then post-operatively, as I said, we wait in the OR longer. And this is where the institutional commitment comes in as well, because there's no push to say, we want to do 2 cases in the room, because if there was, you wouldn't do Jehovah's Witnesses, right? So usually when I do Jehovah's Witness, it's 1 case, that room, whole day. And then there's not the pressure of having to get the patient out of the room and leave somebody who's bleeding.
What are the differences you see in patients that have a surgery that's bloodless versus someone that gets a lot of transfusion?
Well, we publish on this, or we show that by not transfusing blood, you reduce your primary graft dysfunction, which means for lungs, it means that the oxygenation of those lungs right after the transplant is not adequate. We call that PGD in lung transplant. We reduce that by close to 10%, which is pretty significant. As an average is around 25%. So we bring it from 25% to 15, 12% in that manuscript that we published. And we also have shown that it also reduces acute kidney injury and so on. So just from the initial morbidity of a big operation like the ones we're doing, overall the function of the organ that you just transplanted and the function of that patient is significantly better.
When you talk about the bloodless patients, so we define them as patients who definitively refuse transfusions. And that means we use the word definitive because that means that they would accept death over getting blood transfusions. If somebody calls our office and we go over all this before, and if they say, well, I don't want blood transfusions, but in an emergency, I'll take blood transfusions. Those really are not bloodless patients, right? I mean, they're basically almost everybody else that I do. We don't give blood willy-nilly unless they really, really need it. And so if you take the patients who definitively refuse blood, most of them are going to be Jehovah's Witnesses. And what I noticed is that they have a certain amount of faith in their religion, faith in prayer and spirituality, that they come to the operating room much more in peace, and I think much more accepting of what would happen with them because of their faith, that they do remarkably well just from a psychological perspective. I think that's very important on top of the physiological advantages of not getting a lot of extra volume, not getting blood, immunological inflammation, etc. I think there is that physiological component, but a big portion of this is their faith and spirituality as well. When we looked at our reintubation rates and our respiratory failure rates, knock on wood, they're almost non-existent for Jehovah's Witness patients.
Wow. Very good.
You seen that too, Papa?
So well, it's difficult that we like to be within 12 hours of lung transplant. But what I was going to say is that by the time Jehovah's Witness patient come to us, most of the time has been declined at a lot of places. Their risk is pretty significant. So that comes with a little more work after the surgery. So it is rare that measures like time to extubation will be very significant to us. I'm honestly, I'm just happy when I go home and then, in 3 weeks after transplant. So that to me is the win. Because, but like I said, I mean, I'm at least from the lung transplant perspective, and I'm sure within the heart team the same. These patients have received a few no's before they get to us.
You probably answered my next question. Is I was going to ask, what are the most significant challenges in performing bloodless heart and lung? And it's probably that you do get the sickest patients, right? They are almost at that level of being declined by everyone else. Is there any other significant challenges in treating this population? I know you probably have to coordinate travel for some of them because I know they come from all around the world.
I think a couple of things that you brought that are really important, right? One of our biggest challenges is patients who are Jehovah's Witnesses, people know they're Jehovah's Witnesses, and they'll put them through an entire transplant workup. And at the end, they'll try to convince them to take blood. And when they don't take blood, then they just kind of drop them off and they don't actually treat them anymore. And then they usually find us through their HLCs and through word of mouth in their community. And by the time they come to us, if they come to us 6 months earlier, their kidneys were working. Now their kidneys aren't working or their liver isn't working. It's kind of a sad testament to the medical community where if they can't do something, then they automatically say just shouldn't be done. And they don't give people the proper therapy that they could get. Or there have been many instances where when we say we could do it, then they'll turn around and say, yeah, we'll do it here as well. And a couple of those haven't gone very well when they stayed locally. So there is a certain amount of expertise that comes in when you have institutional knowledge of how to do some of these complicated patients. 30% of our entire Jehovah's Witness cardiac practice are reoperations. And those are things that people run away from as much as possible. I would say that the referral patterns and the slow referral patterns and the inability to kind of release these patients early is a problem. The next biggest problem is insurance because, a lot of these do come from the 50 states and out of the countries. A lot of them have insurances that we're out of network for, that we have to fight. And some insurances won't allow them to go out of network because they think that, bloodless surgery that's their preference. It's not really a medical necessity. So we fight hard to get them here. And of course, a lot of people have Medicare disadvantage plans. So I think insurance is an issue. We have magnificent HLCs in Chicago who really go out of their way to be able to set up housing and everything for these folks. So housing is actually less of a problem. It's usually insurance, it's getting here, it's transportation. And for transplant, we do require that they stay in Chicago for a year after their transplant, which, puts a lot of strain on people. But usually after their transplant and they're feeling good, they're happy to be here for a year.
Absolutely. Absolutely.
What would you like to leave our audience with?
Almost any cardiac surgery can be done bloodlessly with some planning and in the right program. I think from a patient perspective, if somebody says no, don't give up and call people who can probably help you. And from a provider perspective, be honest with yourself. And if you can't provide the care, find a place that can provide that care.
Perfect.
Absolutely. Self-advocacy is very important, and that's why we're doing this today. Unfortunately, as Dr. Jeevanandam was saying, sometimes you run into some situations in which people say no, or there is no option, or there is nobody that will do it. Or so podcasts like these are very important to help spread the word. So, I think, thank you for having us here and for giving, the audience an opportunity to know who we are and what we're doing.
If you enjoy the conversations we're having, don't forget to comment, like, share, and subscribe. It helps bring awareness to the importance of understanding decisions when it comes to your blood.